Rappa sir, Tushar
2,
અને અજય
1.
શ્રીવાસ્તવ છે બરાબર.
Please start, sir. We are live, sir.
Okay, good evening, friends. Welcome to again one more episode of the Gujarat WhatsApp group webinars that we have been doing for last more than a decade. There was one lull in between during COVID time when we did a lot of COVID-related diseases, and now this year we have restarted our meeting with several scientific programs. We held first on labs in hematology, then back-to-back two on TB. Last time we had on the joint is angry, that was very well attended by people. And all these are then archived on the Gujarat Pediatrician WhatsApp group YouTube channel. So all of you can go to YouTube and just put Gujarat Pediatrician and the channel will pop up. You can sort of subscribe to it so that you are told when the new episode comes, and you can watch all the episodes. They are going to remain there forever, sort of. Today we are met for a very important topic, that is vaccination. So, and before I hand over the mic to Dr. Ramesh Bajania to introduce the guest and guest of honor, and then to hand over to Chetan Bhai to conduct the session today, I will just show what are the upcoming events. So, I will just share my screen.
You connect from there.
Yeah, you are able to see it?
Yes.
So these are the upcoming two events which I have already planned in the month of July, second Thursday, that is 11 July, again same time 9 to 30 p.m. We will have nephrology in office practice. Again, myself and Dr. Ramesh Bajania will moderate that session in a question answer and a case-based discussion form. We have three eminent pediatric nephrologists from our country. Dr. Pankaj Deshpande, who works with me at PD Hinduja Hospital in Mumbai. Dr. Fagun Shah, he's a local nephrologist, pediatric nephrologist from Ahmedabad. Recording in progress. Okay, so from Surat. And then we have Dr. Sushmita Banerjee from Kolkata. And after that, in the month of August, as you will understand today, that we are not going to be able to finish entire vaccination in just one session of 1.5 hours. So we will do as many as required, but we'll try to address every question that has been posted in the different Gujarat WhatsApp groups. So we have selected some of the 30 questions for today, but there are more than 100 questions. So we'll have maybe part 2 and even part 3. So part 3 again with the same faculty, we will have in the month of 8th of August. I know the faculty have not been briefed about its date, but I'm sure we can do plus minus if the faculties are not available. But as far as possible, we'll keep the same faculty. So with that, I will end to stop sharing my PPT and I hand over to Dr. Ramesh Bajania to conduct it further. And before that you do, I will like to first thank the sponsors for today's event. Again, Zydus Vaccines. We are very fortunate to have Mr. Nitin Jain, who heads the vaccine division. Please say a few words. Unmute yourself. Yeah.
Once again, sir, good evening and thank you so much. It's been such a scientific piece and we are really proud to be part of that. In fact, the response has been so phenomenal that we have been really motivated to look at the upcoming sessions on that. Just to tell you and give you certain, feedback about what we've been hearing, that we've already got down north, deep in south and east feedback and request that can we support such kind of program, and I said, why not? We can certainly do that because there has been a lot of response and the viewership on this program. So congratulations once again, and we are glad to be part of it and we'll continue to be part of such scientific program. Thank you once again, and thank you for giving us this opportunity.
Thank you. Over to Dr. Ramesh. Please introduce the guests and the guests of honor for quick round, and then we will start the scientific session in another 5 minutes.
Yes. Good evening, all respected seniors and dear friends. Once again, I welcome all to this academic bonanza.
So sorry to interrupt you, but I must introduce Dr. Ramesh. Of course, he does not need introduction, but first of all, he's a great friend of mine. So that is the beginning of this entire WhatsApp group and the chats and the seminars. And more important, he's single-handedly running this 4 Gujarat WhatsApp group since last more than 15 years. So he's the brain behind all these webinars and then seminars and then webinars and all sorts of things. And he, of course, as you know, he has been the EB member. He's very active in environmental chapter. He's from Surendranagar and Dhangadhara. And as I said, again, he's a great friend of mine. Sorry, Dr. Ramesh, please.
Yeah. Thank you, Nitin, for kind words. So we started this in 2015. The motto was very clear, that help for all and help by all. Where does it come from? it comes from the members. And then later on, faculties join. And it has expanded into such a vibrant group of more than 1,500 members. And it gives me an immense pleasure to serve our colleagues. So today we have got eminent faculties, and I'm very sure that this session is going to be a real academic bonanza. First, before that, I'll welcome Dr. Tushar Shah, who is not only a great friend, but he is a AOP Gujarat president also. So, Dr. Tushar Shah, few words of encouragement for all of us, please.
Sure. Thank you very much, Dr. Ramesh Bhai. I know you since very long as a wonderful human being, and as Dr. Nitin Shah told rightly, that you've been working very hard to conduct a lot of academic activities, as discussions also, and as seminars, which is your specialty on this Gujarat WhatsApp group. So I am very happy to see that we are having all experts like Dr. Nitin Shah, who is a legend in vaccine, and he's a mentor for me. A lot of knowledge that I gain from him, and I follow on his footsteps. Dr. Kashi, who is scientific wisdom and a huge face for all vaccine-related issues as far as ECVIP and others are concerned. Dr. Jaideep Chaudhary is also a good friend and a vaccine ID expert. So with all these three as eminent panelists, and Dr. Chetan and Dr. Bajania, who are going to be moderators, I think it's going to be a wonderful academic feast and an academic bonanza for people who want to learn for vaccines. And as Dr. Nitin Shah rightly said, it's not possible to cover such a vast topic and so many queries which we usually have from audience who are going to participate or who participate usually in large number to finish in one episode. And so we are going to have plenty of episodes coming. So I wish you all the best, and I hope that we all learn a lot and practice the right kind of vaccinology now on. Thank you very much for having me here as guest of honor.
So,
Over to
just
you,
one
Dr.
minute, Ramesh bhai. We are very fortunate to have Dr. Yevle joining. Dr. Yevle,
Yes.
please put on your video. You're the fourth vaccine expert of giant category. And
Yes, sir.
while Tushar bhai, you were saying, I must also say that Dr. Kasi is also my vaccine guru.
Right. True, sir. True, sir.
अरे
He's a real
भाई
vaccine guru.
Ramesh bhai.
So we have got
इतना
gurus of guru.
Yes.
इतना नहीं चढ़ाना मुझे.
नहीं सही है सर.
Welcome, Yevle sir. You are host as well as guest. So now our second guest of honor, very, very dear friend. I mean, he is an asset to Central IIP, whomsoever is ruling at the helm of the affair, but he is indispensable. Dr. Jagdish Chinappa. So I welcome Dr. Jagdish Chinappa, sir. Please, a few words for us, all of us, inspirational. I know that you are a wonderful personality, multifaceted. Over to Jagdish, sir. Jagdish sir, unmute, please.
Unmute
Jagdish sir,
karo,
unmute. Jagdish bhai, unmute, please.
हाँ जी. Am I audible now?
Yes,
yes,
loud
yes,
and
yes.
clear.
Okay.
Yes, perfect.
Thank you, Ramesh bhai, for the kind invitation to be a guest of honor today. And I think today we are going to have the World Cup finals of vaccinology. We have the next 1 hour. We have two fast bowlers from either end, Dr. Chetan Trivedi and Dr. Ramesh Bajania. And to face them, we have got three superbly talented batsmen. We have Dr. Nitin Shah, Dr. Kasi, and Dr. Jaideep. And if any of these people miss one of those balls, we have Dr. Vijay Yavle and others also who are there to take care of the issue. So I think today's match will be very unique because I don't think you will require a third umpire. Because all of them are going to keep backing all the questions and queries out of the park. And I think we're going to have a memorable evening. So I think congratulations to Dr. Ramesh Bhai for this fantastic idea of yours, and to all the panelists. Let's get the ball bowling now.
Yes, thank you.
Thank you, Jagdish sir. Now, straight away going to the webinar, I hand it over to Dr. Chetan Trivedi, who will be opening the inning. Yes, Dr. Chetan.
So 1 minute before Chetan,
Yes.
we have several other guests who have joined. Dr. Sonamne, I can see, Dr. Jalil Ahmad, Baldev Bhai, good evening, Karuna Karan, Dr. Jai Kapoor, Dr. Vani, Dr. Johnny, Mrutyunjay Das, so many of them. So I'm very happy to see so. And of course, we have Dr. Rajsekhar, which who is a pioneer now in the ACV.
Evening all.
So over to Chetan Bhai to start the webinar on the vaccination.
We are blessed to have you all. Welcome. Yes, Chetan.
Thank you. Thank you so much. Thank you, Dr. Nitin Bhai and Dr. Ramesh Bhajana, for this wonderful opportunity to host this particular session where, it's like nowadays I read Gita and Arjun Vishad Yoga. Arjun is just standing in front of this thing, and then he's saying, oh, Dronacharya is there, Bhishma Pitama is there. How can I fight? Here it is not question of fight, but asking the question. But then the Krishna is the Bhajana sir. He said, you don't have to worry, because as such, whatever you ask, you are going to give the answer. So our job is karmanye vadi karasta ma kalafaleshu garachana. Matlab, ask the question, forget about the answer. So that way we are going to have this particular session. So welcome Bhishma Pitamaha, Dr. Kashi sir, vaccine sir, Dr. Nitin Bhai, and a good friend, Dr. Jaideep Chaudhary. He's been inspiration to all of us always. And of course, Dr. Bhajana will be there on the non-striking, and at present I'll be taking the strike. So I'll be just sharing my presentation. Presentation is not a presentation, it's a question bucket, which we have got from our side as well as what we got from the audience. So we are just trying to make everything under one roof. As everybody knows that vaccinology is not a subject which can be covered maybe in a day, 2, or even 7. We know that. But still we'll try to justify them by making it 2 or 3 episodes. So today what we are going to talk about something like basics of immunology, general consideration. We'll be taking BCG, hepatitis B, DPT and IPV. This much I think we can cover in an hour. We can justify the topic, and then we'll be having lots of questions. So I'll request all of you to just put the queries of these 4 things only. Don't put the queries of other subjects, because we would definitely justify them in coming episodes. So herewith I start ball rolling.
So just before that, Dr. Chetan, I need to ask the admin any question which are put on the web stream by the delegates, because most of the delegates are on the web stream. Who is going to collect and give it to Dr. Chetan, or Snehit, or anyone who's there?
I think Snehit can do it.
Okay, so I think I will call him up, because probably he's in the background. Sure. Okay, continue, sir.
Yeah.
Sorry.
And
Yes,
I hope, Bhajana sir, people are able to open the stream go. Just check it out. 1 or 2
Yeah, we are
messages.
live. We are live. We are live.
Yeah, I again reposted the one which Nitin Bhai shared later on.
No.
Yes,
This one.
even I can understand your apprehension. I have again reposted the last the Dr. Nitin Bhai.
No, I got some messages that people are unable to join in the stream go.
Oh, is it? Okay. Then wait. Let me try
So there
first
are-
myself.
Nitin Bhai, please sort it out and share with me so that I
One
can
minute,
post it all
one
in
minute,
the
one minute,
group.
one minute.
Just
one
a
minute.
minute.
Sagar Vinayak Karad, he said he couldn't. Now Kamlesh Arya also, but now he could join.
Acha.
That is, it's working. Now let me say 2 or 3 messages came. That
No,
So-
Chetan. After that, I have posted, and now the people have started joining. The one which Nitin Bhai posted later on, if you remember.
Okay, fine. Okay, so I think
Nitin Bhai, the one which you posted right now to me, na?
No, that was the speaker's one. Let me see.
That I have shared amongst the dignitaries.
no. But
the one
stream-
which you shared in group, na, that also I shared amongst
This
the
stream go, same link. No, I am able to open it.
Yeah.
Okay. The
No,
people
no,
are-
we are live. I have also joined it as a
Okay,
delegate.
done.
So I think no worries. Just
Chetan,
continue. Yeah.
That's
All right.
good.
Okay.
Chetan,
Yeah.
just do one thing. You message that particular, forward it to me. Again, I'll share it.
I've shared it. Okay, fine.
Ah.
Fine. So let us start the ball rolling, and I think who other than Dr. Kashi sir can be facing the first ball. Sir, we have different vaccines, live vaccine group and the killed vaccine group. So what I want to understand, because whenever a new vaccine come, whether it is live or killed, we just try to understand the thing. But basics is, what is the basic difference which is clinically relevant between the live and killed? Second is, which is better immunologically? Third is, what is the difference when you talk about this killed and live? What about the booster requirement? And what I heard, or I got the information that live is better than protein, better than polysaccharide. So can you just justify this in your own this thing?
Okay.
Because you are best in this, I know.
Thank you, Dr. Chetan. First of all, I'm really very thrilled to be part of this Gujarat WhatsApp group. I have been a spectator all this time, and I'm very glad to be on the other side of the desk now. Now, coming to the question, we have two groups, basically two large groups, killed and live vaccines. Killed vaccines are either the whole pathogen, which has been inactivated by either physical, chemical methods, or more recently by genetic methods. And generally, it may also contain a part of a pathogen, like say a subunit vaccine or some sort of a capsular polysaccharide vaccine. These are all inactivated vaccines or killed vaccines. The correct terminology is inactivated and not killed. Now, when you administer an inactivated vaccine, say X milligram, the body also gets only X milligram. There is no multiplication. After administration, it goes to the regional lymph node only. There it interacts with the MHC class 2 receptors. You get a CD4 response, which is predominantly a humoral type of response. And this type of response is adequate for predominantly extracellular organisms, diphtheria, tetanus, Hib, pneumococcus, etc. Proteins degenerate over a period of time. So antibody titers wane, and there is a need for periodic boosters if you want continued protection against these organisms. Coming to live vaccines basically are attenuated by cilial culturing under unfavorable conditions, or more recently by genetic methods, codon deoptimization, etc. When a live vaccine is administered parenterally, X milligram multiplies. It can become 10x or 100x. It goes to the bloodstream, to every nook and corner, multifocal lymph node stimulation, interacts with class 1 MHC receptors. You get a CD8 type of response, which is predominantly a cell-mediated immune response. Now, a cell-mediated immune response is crucial for intracellular pathogens like viruses, protozoa, etc. We must also remember that when you administer a live attenuated vaccine, some amount of the vaccine antigen remains in the reticuloendothelial tissue for a very prolonged period of time, constantly stimulating the immune system and producing antibodies. And that is the reason why following successful vaccination, oh, who's that? Following,
yes. Continue.
So following successful immunization with a live attenuated vaccine, immunity is almost lifelong for almost all the pathogens except some like maybe mumps, and you generally don't have to give boosters. You give a second dose only to take care of primary vaccine failure or for programmatic reasons. So to summarize, definitely live attenuated vaccines give a better immunological response because to some extent humoral, to large extent cell-mediated immune response, and you don't need boosters. Now, coming to the last part, I think it's a well-known fact that immunologically, live is better than an inactivated, especially a protein antigen. And a protein antigen is better than the polysaccharide because, as you are all aware, polysaccharides are T-cell independent. They're not effective before 2 years of age, predominantly IgM type of response. You don't get herd immunity. There's no memory cell response. So definitely it's not as good as either the protein or the inactivated or the live attenuated vaccines.
So just to add, Chetan, we have lost Chetan or what?
No, he's here.
Ajay. So just to add to what Dr. Kasi, unfortunately, we are not able to test the T cell response to most of the vaccines, unlike we do the antibody. So let's suppose just a classic example, you have an inactivated hepatitis A vaccine, not one but two brands. Of course, many more in the international market, and you have a live hepatitis A vaccine. Now, people compare the two on antibody response, which is not fair because live attenuated vaccines induce antibodies, which are usually hundreds, whereas live killed vaccine or the inactivated vaccine will induce an antibody response which is in thousands. So while you may compare for the reason of non-inferiority or otherwise, but you are not able to justify comparing a live with inactivated just on the B cell response, because the predominant response by the live vaccine is a T cell response.
See, basically a live vaccine behaves like a natural infection, whereas an inactivated does not behave like a natural infection. That's a very crucial difference between an inactivated and a live vaccine.
Absolutely.
So both infections, matlab, those have been covered by live or killed. Ultimately, boostability is there with both, right?
Boostability is there, but the need for boosters is not there for the live attenuated vaccines.
Correct, correct.
Generally, with viral vaccines, you don't get a booster anamnestic response when you give a subsequent dose. You just get some increase in antibody titers. Again, comes down to baseline levels in a pretty short period of time.
So what I understood from Nitin Bhai is, if you check the antibody titers, the live may be underperforming at that particular time.
Yes.
But ultimately, it is going to last longer as well as natural boosting, and it will be multifocal all throughout the body. So it will be giving a better immune response as far as possible as compared to killed vaccines.
So just to exemplify by an example, like you take measles vaccine. You give one measles vaccine, you have around 85% seroconversion and seroprotection. The 15% probably will not respond to the first dose. When you give the second dose, you achieve almost 95 to 97%. And that's the reason why we give the second measles dose, not to boost the first dose.
Right.
Anyone who has acted first anyway is a sort of a superfluous dose. But catching the remaining 50, because unless you have 95% community immunity, you cannot curtail the outbreaks or the transmission. So that's the basis behind two measles. That's the example how you can understand.
So, sir, you very specifically said mumps. Even if it is
Ramesh Bhai, can you mute yourself? Yeah, go ahead, sir. Sorry.
Yeah, Chetan. Yeah.
So mumps, you rightly said, that's an antigen, like particularly when even if we are giving a live vaccine, it is underperforming. So what may be the reason?
Well, as far as mumps in particular is concerned, somehow it is not an antigen which is as efficient as, say, mumps, measles or rubella. The number of memory B cells elicited by the mumps vaccine is much less compared to what is elicited by measles and rubella. Maybe it is inherently defect in the mumps antigen used, irrespective of which brand you're using.
So just to add, Chetan, by that, it's not that just because you have a virus and you have viral vaccine is going to be excellent with one dose or two dose. There are several viruses for which we don't have vaccine.
Yes.
And we are not able to make. Typically, RSV. RSV is so extremely difficult to make a vaccine. Now we have with great difficulty made some adult vaccine, but not for children. So in general, principle is correct, but there'll be exception to this principle that some viral vaccine may not be as potent as the others. Like you take hepatitis A vaccine, you take one dose, killed, inactivated, live, etc. It is such a potent antigen that you have lifelong immunity with even vaccine like a natural infection. Whereas mumps 3 doses and yet we don't know what will happen after third dose.
So mumps is the such only antigen where you need even live vaccine. We have to give because there is waning of antibody, and that's why you need a booster. What we are giving at 4 to 6 years to cover up the later age group. Okay, fine. Fair enough. Now let us go.
Whereas the other example is yellow fever vaccine, where we take one dose at 9 months of an inward lifelong. Now we don't need booster. So such potent vaccine. So in general, yes, viral, very good, 1 or 2 doses, but some exceptions.
Right. So now, Nitin, my second question for you.
Yes.
By mistake, somebody has given MMR vaccine IM instead of subcutaneous. What can be the consequence? So what I want to ask is, what are the vaccines which, if given subcutaneous, instead of IM, need to be repeated? And you can discuss it out intradermal versus subcutaneous versus intramuscular. What is the best response and basic science behind it?
Yes, correct. So most of the live vaccines are given subcutaneously because you want a live vaccine virus to remain in the body for long. And the absorption from the subcutaneous area into the bloodstream is poor. And that's the reason why it will allow a prolonged stimulation of the local immune system, whether at a regional lymph node level or even in the skin dendritic level or the subcutaneous local area dendritic level. So that's a good thing. But if that vaccine is given intramuscular, like say MMR is given intramuscular, it will be as effective as subcutaneously. It's taken as a valid dose. There is no need to repeat it. But that doesn't mean you give it by choice, but by mistake, if you're given, that doesn't matter. Same is true for varicella, same is true for live Hep A vaccine. So live vaccines, subcutaneous given IM are a valid dose. Now the reverse, most of the other vaccines are given intramuscularly. What if they are given subcutaneously? So suppose you are given hepatitis B by mistake subcutaneously. In children, it may not matter because they have a very potent immune system. But it has been shown that in adults, if you are given subcutaneously or even intramuscularly in the wrong area where gluteal region, where there is a lot of subcutaneous space, the vaccine might not have reached the intramuscular plane. It is poorly immunogenic. So that is not taken as a valid dose, and probably you need to repeat that dose. Coming to PCV, coming to DTAP, WP, DTAP, HEB, these three vaccines have to be given intramuscular because there is no study with these vaccines. If they are given subcutaneously, what happens? Remember, you should never give an adjuvanted vaccine subcutaneously because it's very toxic. So not only there'll be no effect, but there'll be severe side effects. The only 2 or 3 vaccines which are intramuscular, but if given subcutaneously are a valid dose, beside the live vaccine, are the meningococcal vaccine, the influenza vaccine. So these 2 vaccines, and we know that if they are given subcutaneously by mistake, that's taken as a valid dose. So that is in general the principle of giving the intramuscular, giving subcutaneously, which to repeat, which not to repeat. And remember, in rabies, don't play along with the rabies vaccine. It should not be given subcutaneously. If it's given, it's an invalid dose. You should repeat it. It can be given intradermal. That's a recognized route, but of course, that's a different ball game. And never give it again rabies vaccine intramuscularly in gluteal region, even in children. Because if it's given in children intramuscular in gluteal region, it's taken as invalid dose and you have to repeat it. So in general, we used to think that intramuscular is the best route, but now we know with live the subcutaneous also works well because they have a different mechanism of action, as Dr. Kasi explained very beautifully. The new route that has come is intradermal. The intradermal is either through an injection, like using a needle, or using a gun injector, what you call transdermal injections, which can also go intramuscularly. And the third is, of course, by the skin patches, which are the in thing which are going to happen in the future. Now, how an intradermal vaccine works is because intradermal area is very rich in dendritic cell, which are the antigen presenting cell, and they will migrate to the regional lymph node and stimulate the lymph node to respond to the antigen which it's carrying in as good or even sometimes better manner as compared to what is given intramuscularly. So there are vaccines like IPV which are given intradermal, there are vaccines like rabies which are given intradermal, and many other vaccines are coming in this way. The last question is, which is the best immune response? It depends on the vaccine. So it's not that one is gospel truth. Like if you give intradermally, we know the seroconversion is very good. But the titers are generally lower. Like so you compare intradermal IPV with full dose IPV, three dose versus 3 dose, then the titers will be almost half with intradermal. Now, whether titers matter, that depends on whether the disease is prevalent. In today's time, in polio, it may not matter so far as someone is protected by seroconversion. And especially now that we know about this B cell and the T cell memory cell by many vaccines in an immunocompetent person, once you are stimulated and your anamnestic response, if you have not a very short incubation period disease like meningococcal disease, where you may not have enough time for the anamnestic response of 72 hours and you may die before that, where you need a ready-made antibody all throughout. For most of the other disease, you have enough time to have an anamnestic response. So probably there it would really not matter. So that is essentially the answer to this 4th question that you posted. Dr. Kasi, you have anything to add?
Nothing except that the type of the antigen presenting cells in the intradermal tissue is different from morphologically and functionally different from that is present in the subcutaneous or intramuscular. So the type of immune mechanism itself is a little different and probably more efficient because it functions well even with much lower antigen loads.
So most of the intradermal vaccine, Dr. Chetan, are actually dose-sparing vaccines.
Yes.
So when you have a problem of availability of the doses, like IPV, suddenly whole world has to take, say, 5 doses, whereas the manufacturers giving intradermal 0.1 ml is a good idea. Like same way, you have an adjuvanted IPV, which is 1/10 the dose given intramuscular. Yes, a dose sparing. You can, instead of giving intradermal, which is cumbersome and training is required, people know how to give intramuscular. You have the adjuvanted IPV available. So like that, there are many things which are done to essentially dose sparing.
So
again, when you use rabies intradermally in the public health, it is essentially dose sparing because the tissue culture vaccine was not easily available, say 10 years back.
But rabies, there is enough data to show that intradermal is almost equal to intramuscular. It's not really inferior at all.
Absolutely. Provided you give it properly intradermally.
So we have success story with the IPV, we have success story with BCG, we are giving with so we have different vaccines which can be given. Even rabies is a success story. Dr. Vijay wants to say something.
Chetan, sorry for intruding, but since you are discussing basic vaccinology at this point in time on discussion between inactive and live, let us ask Dr. Kasi the concept of instead of prime boost and the like mumps, varicella have behave a little differently. If you could enlighten the listeners on
Sir,
this.
my next question is that only.
Okay, okay, okay.
I have not shared the slides, but I think you share the thoughts. So, Jaideep, you can now pitch in. Some vaccines, they require frequent boosters. So what is the logic behind these boosters in particularly rendering this protection? And, what is the role of that boosters? And because we know that primary vaccine series, we keep a gap of 4 weeks, and then we say that if it is the second or the interval between the boosters, you have to keep minimum 4 months. We have specific guidelines for specific boosters. So why this particular concept of this interval between the vaccines, Jaideep?
Good evening. Thank you. Now, the primary response, immunological response following vaccination is the IgM, which rises fast, then it declines also fast, maybe around 3 weeks. So that's why if we give repeated primary dose, then it maintains the IgM level to some extent, which gives some immediate protection and also continues stimulating the immune system. Now, as the say 2 or 3 primary doses that we give at around 4 weeks interval, the IgM will definitely fall after that, but gradually the IgG picks up. Now, as the IgM falls, if we give a booster dose, say at least after a gap of 4 months, then that boosts the immunity and the IgG level develops, and that gives a sustained immunity. But at some point of time, definitely the IgG will also decline, and then the memory cells take up, and that's the anamnestic reaction that we were discussing some time back. Now, regarding the frequent boosters and the less number of boosters, that's mainly dependent on the incubation period, primarily dependent on the incubation period of a particular organism, like say pertussis, where the incubation period is small. We need frequent boosters so that the after an attack of pertussis, the immunity picks up. But a disease which has got a long incubation period, like say hepatitis A, there we do not need such a frequent booster, because then the anamnestic reaction has got enough time to counter the assault. So that's really the thing behind the frequent boosters and the interval.
I will just add, Chetan, that this gospel truth of 3 primary and 2 booster is just time tested by manufacturers, and no one will dare to break it. But I think UK should be given the real pat on the back, because they were the first to stop. Instead of 3+1 heap, they say 3+0. But they failed because without booster, there was breakthrough heap in the 3rd year. So they introduced the booster. So when it came to PCV, they made 2+1, and that worked. And now they give 1+1. And when you know about HPV, we said 3 doses, then we said 2, now we say even 1 dose is enough between 9 to 20 years. So probably, in effect, yes, what Jaideep says perfectly right. Prime boost is required for most of the non-live vaccines, but maybe we are giving too many doses for at least some of the vaccines.
Too many primary doses.
Yes.
Yeah,
right. See, one comment about the duration between the last dose of the primary and the booster. We say generally should be at least 4 to 6 months. And the reason for this is that you require adequate maturation of the cells that have resulted from the germinal center reaction. Now, memory B cells, which leave the germinal center and go and sit down in various pockets within the body, affinity maturation continues even after the germinal center reaction has ceased. And it has been found out that you require a minimum of 4 to 6 months to have an adequate affinity maturation, both quantitatively and qualitatively. So that's the reason why if you give boosters too early, your boosting response may not be very adequate. 4 to 6 months is the ideal gap.
And the other part, about this gap between 2 doses, Of course, if you're using the same vaccine, what the previous speakers have said, absolutely right. But we are using different two vaccines for the same disease. Like say you are using a conjugate pneumococcal vaccine and a polysaccharide vaccine. In adults, we know that if you give within 1 year in a non-immunocompetent person, then because you're giving 23 serotype, 50 microgram each, it's a sea of inflammation that's happened. CD4 cells are haywire. You give another 13 valent conjugate vaccine with some 2 and 4 microgram, it will be lost in the sea. So you give 1 year, imagine it takes 1 year for the whole cytokine storm to settle down before it can recognize a similar antigen but in a conjugated form. So except for immunocompromise where you cannot delay, you delay for 1 year. So imagine. So that is the way immune system works. So if your immune system is hyper stimulated, then you have to give time for the fire to douse before you introduce another dose. Otherwise, it will be lost. It will be superfluous.
Very true. So that's a very important concept of prime boost, and then difference between the booster dose, what we have to keep it. So that was about this very important aspect of interval between the vaccines. Now, there is importance of age in vaccine uptake. I think that what we are utilizing this knowledge, because you know that PCV initially we need, if we give in within first 6 months we give 3 doses. If it is 6 to 12 months we go for 2 doses, and in second year you go 1 and 1 booster. So why this? What is the importance of age? And also, admin, can you mute all other than the speakers, because there are people who have been keeping it on. So you know that certain vaccines we are not giving it before 6 weeks. So we are just waiting for age. So what is this all concept of importance of age? I think I must say, whatever, Kashi sir or Nitin bhai.
Kashi wants to take it? Me?
Nothing, you begin. I'll.
Okay. So see, remember, first of all, you give a vaccine where it will work. Now, if there are maternal antibodies which are going to interfere, then you obviously wait for the maternal antibodies to disappear. And the classical example is for the first 3-4 doses that we give, like the polio or for the DPT, Hep B, and for the Hib, etc. There are enough transplantable maternal antibody which would remain for 4 to 6 weeks or even up to 8 weeks. So you don't start any of these vaccines before 6 to 8 weeks. In fact, Western countries started at 2 months, that is 8 weeks. We say in EPI countries maybe 6 weeks because the disease is in early and the mothers may be malnourished, so they don't transmit too many antibodies. Now, some maternal antibodies will remain for 9 to 12 months, like against measles, against mumps, against rubella, against varicella, up to 12 months. So you don't give those vaccines before 9 months or before 12 months. If you give them, then they will not work as good. So this is the concept of transplantable maternal antibody interfering with your childhood vaccination. And the same is also going to be true when you're going to give mother a vaccine during pregnancy. Like suppose you give RSV vaccine, you are giving Tdap vaccine. I mean, we know classically that if you have given Tdap to the mother, then the antibodies passed on from mother to the child. They actually interfere with the 3 primary doses.
Right.
Till the time you give booster, when the antibodies become the same as in a child born to mother who is not received Tdap. So, you know, there's a lot of this different concept of natural immunity versus a vaccine-induced immunity, especially if there's a recent vaccination given to the mother. So that's as far as the starting of the vaccine is concerned. Now coming to number of doses in the private, like suppose you have, you talked about PCV, that was so true for Hib vaccine. That as you grow, you develop nasal colonization with many of these common organisms. Like in PCV, of course, there are so many 90 serotypes. So a lot of them are in the nasal cavity. They will induce natural antibodies. So as the age advances, you will have some antibody in your serum against many of the serotypes, especially those which are carried in the nasal carriage for a long time. So as you grow, you need lesser doses than to boost, because you are actually then boosting it because there is already a primary work done by the nasal colonization. So that's the reason why when you start very early in life, before enough colonization happen, you need 3 primary doses to achieve the same target of antibody or protection as you would say between 6 to 12 months with 2 primary, or after 12 months just 1 primary. And the booster that you're talking about is in all these through groups to again maintain the antibody titers at a higher level to protect them till 4-5 years of age, because we know pneumococcal disease is most prevalent in the first 2 years, and in some countries also between 2 to 5 years. So that's the reason behind why you give lesser number of doses when you start for the first time as compared to a child who's born and 6 weeks onwards, or till 2 years. How do you? And after 2 years, you just give 1 dose for PCV13. So, and after 5 years, so definitely you just need 1 dose, because they are all actually now acting as a booster.
Another aspect is immunological immaturity in a newborn. Every aspect of the adaptive and innate immune response is deficient in an extremely young infant. Right from the number of pathogen associated molecular patterns, the interaction, the germinal center formation, the number of follicular dendritic cells, even the quantity of IgG antibodies, the memory B cell populations, everything is deficient in a newborn, except the T cell responses, which are well preserved. So BCG we give, it works very well. Now, as the child matures, one is immunological immaturity lessens and becomes more mature, plus there is natural exposure, as Dr. Nitin pointed out. So that's the reason why in the first 6 months we give 3 priming, 6 to 12 months 2 priming, and above 1 year generally 1 priming.
No books can explain this concept so nicely that these two people have explained us, because this is a very important thing, because vaccinology is a big science and it is really building up on the basic concepts, and this is what we are clearing the concepts. Thank you so much.
I think I would say, Dr. Chetan, that vaccinology is actually pure logic. If you understand the basis of immunology and why should one respond and how one responds, you are very clear. You don't have to mug about this.
That's why we kept 5 or 6 questions like this only. Maybe
Very
this
good.
is concept clearing.
Correct.
Okay. So now next is this catch-up vaccination concept. So Kashi sir, you just take it up. 8-year-old child who has been vaccination naive, there is no vaccine given. Now he plans to ship to USA in next 3 months. So what can we plan? How many vaccines we can give, and what is the concept of multiple vaccines? Because what Nitin Bhai said, that too many antigens in one vaccine, there's a sea of antibodies, and so what body will react to so many antigens? So can we just clear this concept of many vaccines at the same time?
Okay, I'll answer the second question first. Okay. Any number of vaccines can be given at one particular time. Studies have shown that the human immune system can respond to at least 10,000 antigens at any one instant. And there is no vaccination schedule, even if you use a WP vaccine, where you have more than 10,000 antigens. So the only limiting factor is the acceptability for the parents. You can give any number of shots. So let's get this very clear. Now, coming to the first part of the question, I mean, it's a little odd that the guy who is educated enough to go to USA has not taken any vaccines for his child. Anyway, let's assume it has happened.
This is real life scenario.
Oh, love, that's really amazing. Now, when you need to do a catch-up schedule, there are certain things you have got to be very clear about. First, draw a list of all the age-appropriate vaccines that he has to take, the number of doses, and the schedules. Look for any interaction between vaccines, where 2 vaccines you cannot give together, or the interval between doses which may interfere with one another. Third is prioritize. For example, if it's an infant not received any MMR and there is a measles epidemic, giving an MMR becomes crucial. If he's in a JE transmission season and he's in a JE endemic district, giving JE first becomes important. If he has come into contact with varicella, giving varicella becomes important. So prioritize according to what is necessary. So if you take this particular child, now he's 8 years old, there's a high probability that he may have been exposed to tuberculosis and may have reacted and become tuberculin positive. So before giving BCG, I would prefer to do a pre-BCG MAN2. If negative, I will give BCG. If positive, I will probably not offer to give BCG. DPT, IPV, and HIP, the usual classical schedule of 016. Now, 6 months is not going to be here. Discuss with him, can I give the third dose at an interval of 8 to 10 weeks? As I told you before, it's not optimal for the immune system. But if he wants to complete the schedule before he goes and does not want to keep leftover doses for USA, I will give instead of 016, I may give 01 and 3 months also, because he's going to remain for 3 months. We must remember that this schedule may not be acceptable to the CDC. They insist on a minimum schedule. So they can opt either for additional doses or doing antibody titers after going there. I will also give maybe 1 dose of PCV, because he has never received any PCV in the past. It's not that PCV never occurs in older children. It can. I mean, data from our country show that pneumococcal is a significant cause even in the older children and adolescents also. The Indian Incline study has shown that.
Recommendation is immunocompetent child is above 6 years. By 5 years, we don't give it.
That is true, but
Okay.
I mean, okay, let's keep it. That's why I said I may offer a PCV.
Okay.
It's not mandatory.
Right.
Okay. Now, HIB definitely is not necessary for this child. I'll give 2 doses of MMR and chickenpox both on the same day, at least 4 weeks apart. If the strain of influenza that I'm using is a Northern Hemisphere strain, I may opt to give 2 doses of the Northern Hemisphere strain of. There's no idea in giving a Southern Hemisphere strain, which will not be valid for USA. I will discuss the need for typhoid conjugate vaccine with him for his future visits when he comes to India. Hepatitis A, since we are short of time, live hepatitis A vaccine would be preferable. But we must remember that live hepatitis A is not a CDC approved vaccine, may not be acceptable. So I would prefer to give the inactivated and tell him to take the next dose in USA. This because any dose that you give less than 5 months after the first dose is an invalid dose as far as the second dose of hepatitis A. So this in brief is how you should go about when you are dealing with a catch-up schedule.
Fair enough. Fair enough. Fair enough.
What about meningococcal vaccine?
Meningococcal vaccine, as far as USA is concerned, I think it's an adolescent vaccine. So he can go there and take it. If I give it now, the protective efficacy lasts for maximum 5 years. He will have to take one more adolescent dose there. So I wouldn't really consider giving the quadrivalent meningococcal vaccine to this child now.
So I think BCG, yes or no, depending upon MT. MMR, yes, would prefer first, and then we'll get a gap of it. So chickenpox also the same, hepatitis A also the same. And then we will give penta or hexa because now we don't have option of keeping the egg aside. So we will definitely give. Now here age is 8 years.
Yes.
Right? So what exactly? Because penta hexa will give him DTAP.
I know there is an issue over here because above 7 years, see the wholesale, I mean, I'm not talking about wholesale, the full dose vaccines are more reactogenic.
Correct.
But if it is inadvertently administered, I mean, it's not a contraindication. Now, if you are using, say, a Tdap, because you don't have if you have to give the low dose, so that comes to Tdap.
Tdap.
We don't have monovalent IPV. Okay, at least hepatitis B we can give. But what about monovalent IPV? We don't have that now. So I don't know. Nathan, will you give the full dose over here? I would prefer to give that because you have to give all.
If you actually see the literature of tetraxim, I'm taking brand because that's the only vaccine available. It actually was licensed till 12 years of age.
Yes,
so
yes.
Absolutely no problem in giving a tetraxim dose to this child.
So how many doses then?
So you would give him at least 2 with tetraxim because you know 2 IPV 8 weeks apart. And then the third one could be anything. That doesn't matter. Plain DPT, Hep B, whatever you want to give.
Tdap, no? Then
yeah, so Tdap
also.
So you can give 1 Tdap and then 2 at least tetraxim.
So this was a really tricky situation.
The other thing, I usually fire these families saying that, what are you doing here? I mean, you are now going to USA. They will not allow you entry without vaccination. So you are coming running. You want me to fudge your vaccination record. I don't do it. So I tell them that you have no faith in our Indian doctor, but you will listen to even online to what the university there is saying. So I fire them first before giving them the vaccine.
I did that and satisfied myself.
And remember one thing, Chetan bhai, I mean, it's very funny, but that's the way the recommendation are there. When you say that you can't use Tdap after 7 years, 7 years means 7 years and 363 days. Yes. So something happens on the 8th birthday and you can't give it. Don't ask me what.
No.
But
I mean, you just have to draw in a recommendation. You got to draw the line. You're drawing the line.
Exactly.
I mean, you have to use your discretion in certain occasions.
But for all my friends, the concept what Dr. Kashisha made is very clear. You have to prioritize the vaccine, age of acquisition, what can be given, how many how many gap to be kept, everything you keep it out. First, because this kind of patient, ask them to go out and sit, just make a list, prepare your chart and then call them in. Otherwise, it will be difficult situation.
And before giving the vaccine, tell them the total cost because you are giving too many on the same day.
Yes. So now, last from my side, the common query is, one is, sir, when we take that vaccine out of this refrigerator, right, and we prepare it, when we feel it, and many times pre-filled syringe, they have been very cold. So is it required that you have to just warm it with in the palms and give it? Just because ultimately we are giving a very cold shot to the child. So what is the science behind it, Jaideep?
No, actually, we store all the vaccines at 2 to 8 degrees centigrade, and then when we bring it out and we administer, there is no need to just rub the syringe with in the palms, because what the two concern is, one is the immunogenicity and second is the pain as a side effect. Now, in this temperature, there is no question of compromising the immunogenicity because it's an acceptable, and there is hardly any pain if we give the vaccine at this temperature, 2 to 8 degrees centigrade temperature. There is hardly any pain. Only if we push we must be careful to push the vaccine slowly. If the vaccine is pushed very fast, then it may cause a certain expansion in the space and that may cause some pain. Other than that, we should not wait for the vaccine to reach room temperature, or we should not waste any time, or we should not keep the vaccines outside the refrigerator also. So it should be done as early as possible.
And sir, many times what? Yes, anyone? Okay.
No, go ahead.
So I have prepared the vaccine, right? And then the parents say, no, I don't want to give it. Money is not there, or any other reason. I already prepared it. Then what should be done? Then can I give it for some other patient, maybe in same session in the evening, or maybe 4 to 6? Or what is exactly? How can I manage to save this particular dose which has been prepared? Jaideep.
See, if the vaccine and the diluent is separate and we have mixed it, then the recommendation is we have to use it as early as possible. So there is no question of restoring it. So once it reconstituted, maybe we can take 1 or 2 hours. I am not sure. Dr. Kasi, Dr. Nitin Shah might tell that if there is any cutoff of hours, that I am not sure. But it cannot be restored. It should be used as early as possible, maybe within 1 or 2 hours.
So, Kashisha, 2 questions. One is we have
so the classically, like for non-preservative containing vaccines like measles, MMR, etc. Once you have reconstituted, use it within 4 hours, and for those 4 hours, so you keep it in a well where there is an ice well in the diluent. Otherwise, you should discard it.
So can we put it in refrigerator 2 to 8?
No, you don't do it now, because once you've taken it out, you don't put it back this temperature sensitive. So you take out only this much stock as you want. And then once you like typically question comes in a multi-dose where you reconstitute a 5-dose measles, and now there are only 3 children, 2 more are coming. When we don't know what you do.
No, sir. In private sector, we don't use multi-dose.
Sorry to interrupt. Say in the hexavalent vaccine, we have to dilute and reconstitute.
Yeah, but why will you dilute and reconstitute and not use it?
Sir, somebody has refused. That the question is that.
Parents, they are ready for that. Once we prepared it, then say, sir, no. My husband says no, not to give.
Okay, so you throw away the vaccine and charge them.
Sir,
Can I intervene?
Sir, Kashi sir, before you answer, I have 2 questions. One is reconstituted vaccine. That is one thing. And second thing, like hepatitis B multi-dose, I have removed the things, prepared it, and then what to do?
Okay.
Can I put it inside?
Now let's take inactivated vaccines, which generally don't need reconstitution, and live attenuated, which need to be reconstituted. Clear-cut recommendations are there as far as inactivated vaccines, which the entire thing has been activated. Activated means you have broken the seal if it's a pre-filled syringe, but you have not detached the needle. This is activated but still sterile. If the patient has not taken it, you can store it at 2 to 8 degrees for 1 immunization session, which is usually considered as 6 hours. Okay. If you are using a live attenuated vaccine which you have reconstituted, you have to go according to the manufacturer's instructions. I will just give you, because I just did a little reading about this, because even I was not very sure about it. MMR Tresivac product insert states that you can use it up to 6 hours, provided it is stored between 2 to 8 degrees in a sterile condition. Now, coming to the chickenpox vaccines, I will talk about the brands that I use. The product insert for viral states that after reconstitution, if it is kept in a sterile condition at 2 to 8 degrees, you can use it up to 8 hours.
Okay.
Very pet stays, use it within 30 minutes. If not used, discard it. Okay. So I think as far as inactivated, you can have a general rule that you can keep it for one immunization session. But live attenuated, please see the product insert and then take a call on how long you can keep it.
Yes. Anything else?
No, so that's why my first recommendation, always tell the charge to the patient before opening a vaccine.
I know that's a very sensible thing to do.
So
So
until
most of
then,
the corporates, you first make payment.
Yes, yes, yes.
And then only the vaccine is open. So
That's
I
true.
think that's a sensible idea.
That's a good idea.
But having said that, sometimes mistake may happen with us that the patient actually had
Right.
come for MMR and you open,
Yes.
say,
Yes,
tetraxine or
yes,
something.
yes.
If you open it, you should be good enough to say maybe hope that another patient will come who needs that vaccine, but otherwise
That's
throw it
right.
away. Don't
If
keep it back in the fridge and
if it does,
label it and put it in some plastic and all that. Don't do.
no, if you don't use it within the next 6 hours,
Yes.
I think you have to discard it. You don't have a choice.
Absolutely.
yes. Now,
So
sir, this kind
for
of
the
situation-
multi-dose, the government policy is very clear that once you have prepared a multi-dose live vaccine like measles, which doesn't have a preservative, toxic shock syndrome is a known complication. Do
Right.
not use it beyond 4 hours or 6 hours. And for that 4 to 6 hours, you have to keep it in the fridge. Now, outreach program, there is no fridge. So they have these vaccine packs and there are wells inside. So, the whole bulb can go inside, half of it, so that it's still kept in a good temperature rather than just keeping it on the desk.
Yeah, now these wells have been replaced with foam pads with
Correct.
slits in it where you can keep it. It
Right.
probably maintains a temperature better than keeping it in the wells.
Absolutely.
Right. Anyways, so these are some common concept building questions. And now I'll request Dr. Bhajana sir to go ahead with the BCG questions. Bhajana sir, you can take over.
Yes. Thank you, Chetan Trivedi. Now, Nitin bhai,
Yes.
please take BCG. Now, this is a common scenario that 6 months, 7 months, 8 months old child comes and mother complains that BCG was given and still there is no scar. So, what to do in such type of situation? Because this is a very common query faced by general
Correct.
pediatricians.
So see, the science behind says that the only way you test a BCG's effectiveness for whatever protection it offers is by doing a lymphocyte migration inhibition test, which is not possible in our day-to-day life. So 10% of the children who have received BCG correctly actually may not develop scar, which means if you are going to offer another BCG to all the children where there's no scar, you're actually going to give it to many of them unnecessarily. At the same time, you cannot discriminate in a public health program about all this whether it was given properly or not given properly. So it is believed that if a scar is not seen, it was not given properly. So you say repeat it, and giving a repeat BCG is never harmful to anyone.
Yes.
That's why even the IAP recommend that you do repeat a BCG if the scar is not seen by 6 months. Beyond 6 months, it's very unlikely the scar will develop. What I do in my practice, and that is little modification, that if I have given the BCG myself, and I have seen that a bleb was formed of 6 millimeter, and if a scar is not seen the 6 months, I don't repeat it. But if I have not given it, someone else has given, I do not know whether that was given correctly or no. But if you are given BCG in a struggling newborn, it is extremely difficult to really give BCG properly in 100% of time. So in such case, yes, I would repeat a BCG if scar is not seen by 6 months. But if someone repeats it just blindly, that's perfectly fine. That's also the IP's recommendation.
So, Nitin bhai, most of the time, what happens that mother has gone for delivery to her mother's place, and BCG
Correct.
was given by some other pediatrician.
Correct.
So the second thing would be more
Absolutely.
appropriate. Now,
Then give it, yes.
when to repeat? What is the upper age?
So
in case
there
if
is
you
no
want
need to repeat BCG in our country. There is no role of second dose. There used to be second and even third dose in countries like UAE, etc. in the past, but all that is now given up. Even WHO recommends single dose at birth or thereafter as soon as possible in an immunocompetent person. But if someone has not taken a BCG and now suddenly wakes up, then you can give BCG up to 5 years is what I would say is generally the recommendation. But there have been studies done in many European countries, including Sweden and other countries, where they've tried giving BCG to school-going children, they're around 5 to 15 years, and seen whether they can be prevented from getting an active second adult type tuberculosis because of reactivation. So they have found that some BCG helps in different studies from 20% to 60% prevention of reactivation. Based on this study, in fact, the government of India has started a BCG in adult vaccination study where they are going to see whether giving BCG to adults is it going to prevent reactivation. So they will give BCG to those who had past TB to prevent reactivation. They will give BCG to those in contact with the open case recently to say whether they have a asymptomatic infection and they are going to prevent, and so on and so forth. So in the Western country, like if you look at UK guidelines, the guidelines are that suppose some child who has not received BCG in UK is coming to come to India forever, they would give BCG up to 16 years of age. So, I mean, there's no harm in giving to someone who has not taken BCG in past, even up to adolescence, is what my honest answer is.
Fine, fine,
Some
clear.
comments,
Yes,
Yeah,
please.
please,
Ramesh?
please,
Okay.
please, Kasper, please.
Now, if you give 100 children BCG, in our country, the primary vaccine failure rate is about 10%. In some countries, in African countries, it's as high as 30% also. Now, of these 10% who do not have a scar, 90% have a positive LMIT.
Correct.
So in essence, out of 100 children, 99 have responded to BCG. So this is, so from the prevention of TB point of view, probably a second dose may not have much of a role. But there have been studies which have come basically from Guinea-Bissau in Africa, almost 3 or 4, good quality studies where they have found that the presence of scar correlates with better non-specific effects of BCG and reduced mortality and RTIs in the first year of life. So taking all this into consideration, personally, if I don't see a scar, I always insist on a second dose to be given at 6 months.
Great, great, clear. Now, Kasi sir, again, the common scenario is that 11-month-old infant received BCG and developing BCG site abscess and getting ruptured 2-3 times in last 6 months. Normal BCG reactions coming again and again 2-3 times. So what to advise? Because this is a tricky situations.
Now, if you have only a localized reaction, however severe it is taken under acceptable normal reactions of the BCG. Now, this situation, what you have described, occurs either if the BCG has become subcutaneous or it has not been exactly 0.05, 0.5, and for some reason you give a little larger dose of BCG. You do not have to do anything. Nothing to be done. No ATT, no local powdering isoniazid and putting on the BCG scar, nothing. Just leave it alone. It's just going to take a little longer, and maybe 1.5, 2 years. I mean, I have seen BCG scars persisting till 2 years, healing after 2 years of age. You just don't do anything as long as it is only a local reaction.
Right.
But if
So
you have
only
the
reactive.
yes, but if you have the slightest doubt that there may be dissemination, then I think your track changes totally. Then the approach is totally different.
Okay.
Sir, here one cross question. Like there was a question from Dr. Krishnakant ji that he has given BCG. Then he thought it has not been gone, so he just gave again at the gap of something like say 1 or 2 centimeters. Now what happened? Both the scars have come. So how to?
See, I mean, the standard dose is 0.05 ml or 0.1. It does not mean that if you give a 10% less dose, that vaccine is not going to work. I mean, a better approach here was maybe to have done a month to after 8 or 12 weeks, and if negative, you give a second dose rather than giving a second dose right away and creating a mess.
Many times what happens when we are giving, the bleb is not actually of 0.5.
Right.
So we try to poke again and give it so that it is.
No. So what I do is, if I have given BCG and I'm not very sure that I've given right, I would just wait, just withdraw it and finish it off, and ask him to come for follow-up till 6 months. If a scar is not seen, I would give that time. So all you know, sometimes the scar is actually seen, and then you were fooled that you probably didn't inject. So if you have injected in the right layer of the skin, a bleb is nicely seen, but little deep, the bleb may not be seen. It's just little just fullness, but it is still worked.
Right.
There is one more question then. The dose of BCG. I think I know the standard answer of Nitin, right? He says, well, how are you very sure that you have given 0.05?
No, I challenge anyone to give 0.05 exactly in 10 out of 10 children, and I will give them a gold medal.
The question is, Kasi sir, I'm going to ask you. BCG, we standard in 0.05 ml for infant less than 1 month, and after 0.1. What exactly it is?
I mean, I think this is a question which haunts every speaker in every conference, because People are just not happy with the answers. Now, why 0.05? Technically, it is easier to inject 0.05 ml than 0.1 ml intradermally in a newborn. The second thing is 0.05 gives less local reactogenicity compared to 0.1. That's the only reason. There's no immunological reason for reducing the dose. But I think a lot of us use 0.1 ml right in the newborn period, and I don't think it really makes much of a difference. What do you say, Nitin?
Absolutely. I have never used 0.05 ml because
Yes.
by the time you inject, half of it is
Yes.
air, half of it is vaccine. You don't know
Yes.
what went in and what went out. I would really, I mean, my standard is I load actually 0.15 ml because sometimes when you inject, you see in the first push, most of it has come out from the.
Right.
So, I mean, let it be very practical. It
So
does give
usually what we see is a bleb, exactly.
Yeah.
Rather we push it and we see the bleb, which is satisfactory, we remove. So
Correct.
not exactly
Absolutely.
0.1 or 0.15, but it's like that.
I agree with you. I see around 4-5 millimeter, 6 millimeter bleb, and then I remove the needle.
Correct. Yevle sir, you wanted to have some comment.
He had a question before.
Excellent scientific and
अरे
logical
विजय
discussion.
वीडियो ऑन कर रहे
However, there is a conflicting message going out here, because in that patient who received 2 shots at a short interval and there are 2 scars, Dr. Kasi made a statement he would have waited for 8 weeks and then done a Mantu and then repeated BCG. But the recommendation is not to, if there is no scar at the end of 12 weeks, you just repeat a BCG without doing any Mantu. So let's clarify that to the listeners. I mean,
okay. Now, BCG is endemic in our country. Early protection is essential. If your first dose is inadequate and does not elicit a proper response, I personally feel I don't think there's any standard recommendation, but I personally feel that it's not worthwhile waiting till the child is 6 months of age, especially if he's from a low socioeconomic class, crowded conditions, slums, etc. So in this case, about 12 weeks later, I prefer to do a Mantu 8 to 12 weeks later. And if the Mantu comes positive, I'll just leave it at that. The BCG has worked. If it is negative, I will repeat a BCG earlier only.
So I think we are discussing two situations. One is where we have given a BCG and a scar is not formed. You presume probably you didn't give it correctly or something. So there you wait for 6 months. That's perfectly fine. Because ultimately 10% are going to develop scar, but only 10% of those are actually not going to be sort of immunized and protected. Whereas when you're given in haphazard manner, you are not sure that it went correctly. That's not the same as given correctly and not forming scar. So these are two different issues. So that's what Dr. Kasi is saying. If you're not sure that you are not given correctly, instead of giving it immediately, wait for some time. But not wait for 6 months, wait for 2 months or 3 months.
Yeah, Nitin bhai, Dr. Sanjay Deshmukh has asked a similar question that mother has gone for all 3 doses at birth. Then she went home. And after a few days, Anganwadi worker didn't know and again she gave BCG. Now, what to do in such type of situation?
There'll be second scar. There's no other choice. And there might be an accelerated BCG reaction, especially if more than 6 weeks to 8 weeks have passed since the first BCG, whereby instead of a typical lesion seen after 2 to 3 weeks, you will have within 72 hours a reaction that you know that the first BCG actually worked well, and now you have induced another reaction. This is what you used to call BCG test, as was labeled by the senior Dr. P.M. Udani. That when Mantus was not that great available and not great standardized, he used to give BCG to children suspected of TB. And if you see excellent reaction, he would say, no, this is tuberculized child. And probably if you have a clinical setting, that is tuberculosis, So there used to be something like BCG test. So that's it. What used to happen with BCG test. And we have seen some very bad, ugly scar in a huge SHR form when you give second BCG in a child who has received a proper BCG in past. So, don't play around with the second and third dose very lightly. And that scar can be very ugly.
I think this BCG test is something that all of us who got educated in Mumbai have been following very diligently, but it has gone out of vogue now.
Absolutely.
So now, Nitin bhai, again, Sanjay has asked that, but after 3 months, there is no scar by both BCG vaccine mother. So mother is asking whether to repeat once again or not.
No, so I would wait for 6 months.
Wait for 6 months.
Great. Now, Chetan, over to you.
No, so say the other thing, it is Waldo was said that if you gain BCG correctly, you don't have a scar by 3 or 6 months. We say 6 months, you repeat. But suppose after repeat another 3 months, there's no scar. You
Then
don't do third
anything.
dose. So 2 is the maximum. So this child received 2, advertently or inadvertently. That's the end of the story.
The previous question was asked by Dr. Nidhi Patel. Thank you, Dr. Nidhi Patel. Now let us go to the next question. And Here, I would like to ask both Dr. Jaideep and Dr. Nitin Shah. First, Dr.
Wow.
Jaideep.
The third case is my case. The first two
Yes.
are.
So, Jaideep, I have these three scenario. First, one case one. If you can appreciate, there's swelling in axillary region, right?
Yes.
And second case where there is same swelling as other different patient with a swelling with having a suppuration. So how do I manage?
Actually, again, this ideally it's a master inactivity. Definitely, we must not send the pass for test. Then AFB will be positive and it will be more confusing. If there is signs of inflammation, then we can give a course of antibiotic because there may be superadded infection by handling by the caregivers. Otherwise, nothing to be done. If this persists for many months and it's cosmetically difficult, then only we may go for surgical removal. Otherwise, no, nothing.
I think Nitin bhai,
For the second case where there is already suppuration, you can do repeated aspirations from a non-dependent area using a needle and syringe instead of doing a surgery, because that itself may, whatever little pusses that will come out, and that's the end of the
Yeah,
story.
drainage. Yeah.
Whereas the third case, there you have a
just a minute,
lymphadenopathy on
Nitin
the
bhai.
right side. Yes.
Nitin bhai, 1 minute. That's what.
Ah.
I would like to give the very clear history. First thing to all the listeners. First child case one, it is having just a swelling, nothing. We are just appreciating. Just a lymph node is there. It's not creating any problem to baby. So masterly inactivity is fine. Now you just observe this child, and if it is developing suppuration like this, what we have seen, in that case, you might have to aspirate it. Not only aspirate once, you might need it to for second time. And what Nitin Bhai very clearly said, non-dependent fashion. Why? Because it will be a sinus formation. So that is. And Dedeep has rightly pointed out, don't send that pus for the culture or this thing, because it is going to be positive, because there will be a BCG germs are going to be found. So bacilli will be there. So bovine strain will be there. So no need for any anti-tubercular stimulate, or even no antibiotics will be required. Simply you drain it. And now the third case is, yes, BCG is not given on right side. The swelling is a right axilla. BCG is given on left shoulder, and child is having swelling on the right axillary only. Nitin bhai, there is only one swelling on the right axillary. Now
right, but we see many times when you see this bubo in the right axilla, and you of course will first think it's pyogenic abscess, you give antibiotic, that doesn't help, it's going on for weeks, then someone will do a biopsy or an aspiration, send the pus, it will show MTB on gene expert and MTB growing, and it will show it's BCGiosis. You screen this child, and many times you'll see lesion in the liver and the spleen, and there may be lymph node in the abdomen. So it's just when you have dissemination of BCG, though it may be obvious in the right axilla, there may be other areas involved, and you'll be utterly surprised. And if a child is well grown like this, I mean, he looks quite well grown and chubby, then you're not thinking of SCID, that is severe combined immunodeficiency, where the child is miserable, malnourished, diarrhea, pneumonia, and a BCGiosis. This child is more likely to have what is known as MSMD, or the Mendelian susceptibility to mycobacterial disease, where they have only inability to clear mycobacteria and certain other intracellular organisms like Salmonella, etc. So there, the problem is in the IL-12 gamma interferon loop. So either IL-12 is absent, or IL-12 receptor is absent, or gamma interferon is absent, or gamma interferon receptor is absent. Any of the four will lead to ultimately decrease gamma interferon production, which is the one which kills the intracellular organism, like this tuberculosis. So these children then will have to be done a genetic test to find out MSMD. They need treatment with AKT, and in fact sometimes prolonged till time you are able to find out. And if they are SCID, you continue to treat till the time you are able to transplant them. Many of them will come back with relapsing tuberculosis again and again.
One word about case one. I mean, it is very clear you don't have to do anything. You follow them up. Please remember that there is no time limit how long you follow. Even at the end of 2 years, if you have a firm lymph node with absolutely nothing else, you are not going to do anything. It may take its own time. Just don't give, unless it starts softening, you don't have to do anything, irrespective of the period of follow.
Absolutely.
Okay. Now, Nitin bhai, a 4-year-old girl comes and she's from an NRI family. She wants for all cosmetic reasons that BCG should be given on thigh. What should be your answer?
So she wants it on thigh because then she wants to wear sleeveless, so she doesn't want the scar to be seen, as I understand. But I mean, very sorry for the language, but she may also wear a bikini and the scar will be seen on the thigh. How high I will give? It is dangerous. It is not allowed. It is not prescribed. It is to be discouraged because of two reasons. One, it's not a standard area where you give, so people will not know BCG is given. Number two, 1% of children who receive BCG may develop BCG to lymphadenopathy
Adenitis.
regionally, as you saw in the case one and case two, and it suppurates in some. Suppose this girl develops and you are given little high, it will be intra-abdominal or a deep inguinal lymph node which will be involved, which will be difficult to drain, difficult to treat, etc. So I think for that small pleasure of not seeing a scar, I would completely discourage this type of thing. I would never, I tell them you go away, but I don't give, except the left arm, I don't give BCG anywhere else.
Okay, got it. Now, Kashi sir, we know
Yes.
that the BCG has limitation in disease prevention, right? So any new BCG vaccine on the horizon?
Yes. New tuberculosis vaccines is a very, very fertile field. There are almost about 28 to 30 different new TB vaccines in clinical trials. There are about 5 or 6 who are already in phase 3. Some very exciting vaccines. A brief about what is known as a VPM 1002 vaccine. This is a recombinant BCG, genetically modified BCG, where the gene for urease C enzyme, which is present in BCG, in MTB, is replaced by listerio-lysine. And this results in destruction of this MTB within the phagosomes, release of the fragments, and elicitation of an immune response. This vaccine is a very, very versatile vaccine. It is being investigated for prevention of infection, prevention of disease, and prevention of recurrence in those who have already had tuberculosis infections. Now, phase 2 studies where it was compared with BCG showed that adverse effects are much less than BCG, but immunological parameters, T cell responses, were marginally better with BCG. Phase 3 study is going on in South Africa in infants, and proudly we should say that Serum Institute is the main investigator for this particular vaccine. So VPM 1002. There is one more Indian
So,
vaccine under
sorry,
trial.
Kasi, that's the same as the recombinant BCG or the RBCG. People
That
may
is
remember that.
RBCG, yes.
Yeah, yes.
There is one more RBCG which is also being investigated, but it's not an Indian vaccine.
Correct. And there are 2 more studies going on in adults in India with
Yes,
the
yes,
RBCG of serum.
yes.
One is in those who had TB in the past to say
Right.
prevention of reactivation, and second is giving RBCG to contacts of people with open tuberculosis to see
Right.
that they don't get infection from the
Right.
contacts. All
3
these 3
studies
studies are, and we of course
ongoing.
we use RBCG during COVID as a general immunobooster before COVID vaccine came. Of course, it failed. It didn't prevent
Yes.
COVID in the vaccine arm.
Yes. So thanks, Nitin. Now the second vaccine is called ImmuVac. I mean, this is an old vaccine based on an inactivated vaccine based on a strain called Mycobacterium indicus prani. And this was initially used for leprosy. Then they found that it is used for tuberculosis. It's used in sepsis, etc., many conditions. Non-specific immunostimulant. Now, this is phase 3 studies by ICMR along with Zydus. It's being studied for prevention of tuberculosis. In addition to that, there are some other vaccines, which are based on mycobacterial fusion proteins. There are also MTB-Vac, which is again a genetically modified BCG, which is the phase 3 studies are being conducted by Bharat Biotech. I think it has just begun the phase 3 studies in our country. So all in all, I mean, in fact, if VPM 1002 really succeeds, it may replace the conventional BCG and become the primary vaccine of choice.
Just to add to what Dr. Kasi said, there's one vaccine from GSK, which is a subunit vaccine, M72, which has 2 different fusion protein, 32A and 39A. And there is a phase 3 trial of efficacy, which shows that it prevents to the tune of 55 to 60% reactivation. So that's a vaccine which is likely to progress further. And he talked about MTB vac, which is not a BCG, it's not a bovine, it's a human tuberculosis, which is genetically modified. And these phase 3 trials are started very recently.
Okay. Nitin bhai, now we have 10 minutes left and still 2 to 3 questions related to BCG only. So
we can finish
sure
BCG. We can have one session on vaccination every alternate month till we finish all. No worries.
Perfect.
No need to hurry up. Yes.
Yeah, perfect. Now, Nitin, this question is for you. That should I give BCG to newborn of a mother who is HIV positive at birth, and what should be my
Correct.
approach in such case?
Correct. So, what are the problems of giving a live vaccine, which is BCG, which is injectable, to a patient who is likely to be immunocompromised if that baby actually contracts HIV from the mother? So, number one, this child, suppose if it's HIV infected, may not be symptomatic at birth, may have good CD4 count, yet he will have a poor cellular T cell response specific to the tuberculosis in the first year. So, even when you give them BCG at birth, when they are not immunocompromised, the protection is not as good as in a non-HIV infected baby. Now there comes the safety. There were studies done from several countries in Africa and some parts of Argentina where they showed that when they use the BCG, which is either the Danish strain what we are using or the other strain which the Westerners use, both the strain vaccine actually led to increased chance of BCGiosis, which was several fold higher in babies who were given BCG at birth, even when they were not immune compromised, but later on became immunocompromised because they got HIV infected from the mother. Now, that was the era where the antiretroviral therapy was not easily available. So, it was known that there is a latent BCG in the body till 1 or 2 years, which will reactivate and lead to BCGiosis because of immunosuppression in future in such HIV exposed, ultimately HIV infected babies. Now, today, when we use antiretroviral therapy in the mother, we allow, maybe not allow breastfeeding in a patient who can afford, but patient who cannot afford, we give continue antiretroviral therapy and the breastfeed induced HIV has been removed. And the perinatal HIV, of course, has been to a large extent blocked by the ARVT. The less than 1% of the babies who are exposed to HIV infected mothers who are given proper PPTCT prophylaxis would actually get infected. So for that, you cannot submit 99% of not receiving BCG at birth. So that is the reason why WHO said that if you don't know the mother HIV status, if you don't know the baby's HIV status, you just give BCG at birth.
Yes.
But if you know that the mother is HIV infected and you know that the baby is also HIV infected because you have done a HIV DNA PCR very early, like 2 weeks of life, which you can do, then in such case, you should delay BCG till the time this baby is found to be asymptomatic on antiretroviral therapy and CD4 count more than 25%. So that is the current WHO proposition as far as giving BCG to HIV exposed, HIV infected babies concerned. IAP says that just give it because, as I said, less than 1% of babies are going to be infected. For that, you cannot trouble 99% getting exposure to TB and a
Give
TBM
everyone.
and a disseminated tuberculosis, etc. So individually, in a good class patient where you understand all this, what I said, if you do a quick DNA PCR, you can delay BCG for 2 weeks, do a DNA PCR. If found to be positive, delay it till the time you put the child on antiretroviral and is asymptomatic and CD4 counts are normal, give the BCG at that time.
Okay, clear, Nitin. Now, is there any other situation where BCG should be deferred apart from this?
BCG should not be given to anyone who is immunocompromised. So, patient with primary immunodeficiency, patient with secondary immunodeficiency, patient who are on used dose of steroid. But anyway, BCG is given at birth. So, real problem comes in if you have a skid and you are not diagnosed skid at birth because they are looking normal babies. So, in fact, that's the reason why, if you see in the Western countries, a part of the newborn screening program, they do what is known as T-RAGs. And once you have T-RAG positive, you know that this baby is likely to be T-cell deficient, and then you don't give any live vaccine, including OPV and BCG at birth. In our country, that is a dream come true where we don't even do a TSH in a cord blood. So where they're talking about immunodeficiency and things like that. But by chance, if you've done a CB in a baby, okay, who is otherwise healthy, and you find his absolute lymphocyte count is below 4,500, that is, unless proven otherwise, a T cell deficiency. In such situation, I will not give BCG at birth or even after that till I prove what is wrong with the child.
Okay. Now, Jaydeep, in one Anganwadi, what happened that HCW diluted BCG with MR diluent by mistake. So, should we consider this BCG dose valid or should we repeat it? And does it cause any harm to infant?
See, the normal diluent for BCG is normal saline, and for MR is the sterile water. So ideally, one should be very careful. In this situation, when BCG has been inadvertently diluted with sterile water and given, it's better not to repeat the BCG right now. Rather wait till 6 months. If a scar develops, then just leave it as such. Otherwise, explain the parents that we have to see at 6 months. If there is no scar at 6 months, give a BCG with proper diluent. That's my take. Otherwise, there is no need to repeat a BCG right at the beginning.
Okay, perfect. So,
Ashish sir,
Nitin, I think yeah, please.
Kashi sir, any different answer?
See, any vaccine where the diluent is not the recommended diluent is an invalid dose. So if you take that principle under consideration, you've got to repeat BCG. I don't know, in this particular child, maybe I'll give the BCG on the right forearm rather than repeating again on the left, so that you know which is the right one, which is the wrong one. I don't know, Nitin, what do you say
No,
about
I
it?
would do what you would say. You had said before that if I given this type of BCG, I would wait for 8 to 9 weeks, do a Mantoux test. If I see 5 mm tubercle positive, then I know that previous BCG, though it was diluted in water, it worked, and leave him alone. If not, then I would repeat that time.
Okay.
But sir, by that time the reaction should come, no? Before you do Mantoux.
Correct. So 8 weeks. 8 to 9 weeks is the time when MT may become positive, even when you don't have a BCG scar. No?
Yeah.
So
Okay.
When if the
Yes,
scar is not there, the M2 will be positive.
can be positive. Why not?
Yes.
Scar is not the end point for Mantoux conversion.
At least within 2 to 3 months, the scar should start erupting if it is really working.
It does, no? 6 weeks. That's what I'm saying. So if you see a reaction at the injection site in a child who is given like this, I know this is worked. I will leave him alone.
So at least don't repeat it right away.
Absolutely correct. I mean, that's the practical way of looking at it. I mean, there are no gold standard answers to such questions. And of course, you have to reprimand or retrain that lady who did this mistake.
Thank you, Dr. Ashiksha, for this question. I think that was about the BCG. Yes.
Yeah.
Yes.
I think we should
Chetan, is
stop
there
at
any
10:26. Yeah.
Yeah. So is there any question, Chetan, or any expert comments by any of your three dignitaries about BCG?
Any of the participants, there we have 60 of them. So if they want to ask, we can stop sharing, then we can see everyone.
Yeah, but there's a question in the chat box. What is the update
Yeah.
regarding the users' use of BCG, like its immunomodulatory property in nephrotic syndrome child, and is there any role of BCG vaccine in prevention of leprosy and COVID-19? Dr. Sarthak Soni is asking.
So as I said, COVID, it was found
It
it was
didn't
not
work.
useful. Leprosy, yes, we know it does have some cross-reactivity against leprosy, but that's no reason why use the vaccine. Use of BCG for other immunomodulation is not the standard BCG, is the onco BCG which we use in bladder carcinoma and other things, but that's a completely different ball game. The dose there is very high. By mistake, don't give that oncogene vaccine as a BCG vaccine, and you will have massive reaction in the small baby. And we know BCG as such, the byproduct of giving BCG besides preventing tuberculosis and to some extent leprosy is an in general benefit for the child mortality because it's an immunostimulant.
There was one question from Dr. Jalil that nowadays needle-less vaccines available.
So please attend on the 30th June. We have a vaccine CMA at Bombay where I will be touching upon on this so-called painless injectors. To me, they are useless.
Okay, now so I think in 10:27, Nitin Bhai.
Yes.
We are going to hepatitis B.
No, we are not going to go hepatitis B. We'll stop here.
Okay, fine.
Because 1.5 hours. So we'll take hepatitis B onwards for the next time.
Done. That's great.
Great. So anyone from this 50 dignitaries, they have any remark or any? We have 5 minutes. If someone, Dr. Jalil, you want to say something?
Sir, thank you very much. Excellent session, sir. For all. I love the session. Today round, sir, I admitted one 40 days old baby for acute UTI and started on amoxicillin and nicotine. And routinely I checked the BCG scar. The child was having BCG scar, 40 days old. My query is immediately the mother told me, doctor, I didn't have the BCG scar. What I should do? I verified that she didn't have the BCG scar for the mother. How to counsel the mother? And
the mother doesn't have a scar.
Yes. Today it happened today. And this mother studied in UK and then came for delivery here in Coimbatore.
Tell her to enroll in the adult TB program of the Government of India or leave it alone. She has missed the bus by a very long time.
See, once you give a BCG in the neonatal period, generally the scars disappears by adolescence. It's never there lifelong. Unlike the smallpox, BCG scar doesn't remain. She may have had a
Because
scar, it may have
in the
disappeared now.
sometimes we took it as an reassurance because for the cosmetic reason, some of the patient asked to whether we can have it in the site. That's why I asked. And how long I can wait for the primary dose of 45 days? The baby is on antibiotic now for acute
Antibiotics have
febrile UTI.
nothing to do for
Nothing to
BCG. You
BCG.
can give it. There's no problem. There's no need to wait. When the baby is stable enough to be discharged or in an OPD when he's not sick enough, give any vaccine including BCG. No harm.
Along with antibiotic.
Yeah, along with antibiotic. BCG is not killed by any antibiotic, except you give anti-tuberculosis medicine. That too, BCG in our country is ethambutol resistant and not INH resistant. So if you give INH rifampicin, any of those drugs, then yes, it will not work. But otherwise, there's no harm.
Thank you, sir.
Thank you.
Anyone else from the audience before we wrap up this vibrant discussion?
Deepa Joshi wants to ask. I
Yes.
see the hand raised. No? No. Okay, fine.
It's
All right.
exciting to see that only two topics we touched, and that was almost 1.5 hours.
Doesn't matter.
This is the beauty of webinars that we
See,
don't have.
I must have attended, participated, moderated, being a panelist in at least 200, 300 immunization dialogue in my life. Every time the question is same, "Arey, time nahi tha, time nahi tha." Here, no rushing. We may take 10 sessions, but we will answer every question.
Yours must be 1,000, not in 200s. Underestimation. Underestimation.
I was trying to be modest. Hello, Ramesh bhai.
Yes.
Ramesh bhai,
So
wrap it up.
yeah. So thank you so much for this wonderful comparing by Dr. Chetan Trivedi in spite of his personal tragedy, and I must appreciate his commitment to the academics. Thank you so much for a very vibrant discussion, and all three maestros, they did justice to the topic. I mean, the reactions, the messages which I'm getting right now, I mean, it speaks a volume about your contribution to the subject. And Nitin bhai, let us find out the way how we should keep the vaccination sessions regularly in between other sessions.
Sure.
So thank you so much, all of you, they'll say. And
But I will tell you one thing, Dr. Ramesh bhai,
Yes,
that
yes,
in
please.
spite of maybe 2000 immunization dialogue, I still every time learn a point or two from the other panelists. So that's the greatest advantage of joining such sessions. Thank you.
So much of humility. Yes. Yeah.
Good night, everybody. Good night.
Good night.
Good night.
On a happy note, good night, everyone. Good night. Good night,
Good
all the
night, good
viewers.
night.
Good night, all the faculties and dignitaries. Good night.
Good night, sir. Good night.